So today on the Dr. Doug Show, I have an interview with an orthopedic surgeon and friend of mine, Dr. Kimberly Zambito. Dr. Zambito is a board-certified orthopedic surgeon who specializes in hand surgery. She still practices, unlike myself, who couldn't find a balance between the two, but she still practices, but has her orthopedic surgery practice and then also has a bone health practice. She owns and operates a REMS, Echolite REMS machine, which is an ultrasound that can look at both bone density and bone quality. And today we talk about the difference between DEXA and REMS. We talk about the potential margin of error of both, who might consider one over the other, what TBS does with DEXA and how it correlates with REMS, if at all. So if you are interested in DEXA imaging, REMS imaging, or imaging at all for osteoporosis, you're going to want to stick around and listen to this. It's a relatively short interview. I hope you find it helpful. So, Dr. Zambito, I'm so excited to have you here. Another orthopedic surgeon that has really gotten into the bone health space in a way that I can really appreciate. So, thank you so much for your time. And I'm really looking forward to all the things we have to talk about.
Oh, thank you very much for having me, Doug. I really appreciate it. I'm looking forward to our conversation as well.
Yeah, man. So I talked with you, I don't know how long it's been, probably a couple of years ago. It was the first time we actually connected and had a phone conversation. I would love if you could share your story about, you as an orthopedic surgeon, how you got into the bone health space and why you ended up kind of making some of the transitions you did. How did you become this, I would call you a REMS expert, a bone health expert? How did you get here?
Yeah. In medical school, we all have to choose our pathway. You and I both chose orthopedic surgery, and I combined mine with a women's health pathway with the idea that women need musculoskeletal care, and bone health was kind of on the back burner. And as I went through my career and training, I integrated bone health into my career. Became a little challenging. I was in the Army Reserve and was deployed multiple times. So I learned to partner with other experts, rheumatologists, OBGYNs, endocrinologists, other people who could help my clients or my patients who had fractures that I treated work with them on their bone health goals. I then transitioned from a university practice into private practice, and also decided to take a different twist on or a different approach to fracture care management. Rather than looking at bone health from a fragility fracture standpoint, start really involving people with caring for their bone health before that fracture occurs. Oftentimes, as orthopedic surgeons, we see people who fracture, and really we're looking to take care of that fracture, but then I like to take it a step further, which is to prevent the next fracture, but also offer education so that patient's family becomes involved in their own bone health care. And so in doing that and establishing a bone health program, I was introduced to REMS technology by a colleague. And I reached out to the Echolite Corporation and inquired about it, and then started using REMS technology to evaluate bone health and to monitor bone health.
No, that's awesome. And your subspecialty in practice was hand, is that right?
Yeah, I still do hand surgery. I work part-time for a large university network. I still love doing hand surgery. And then the bone health REMS service I do through my own company called Qualisas.
Yeah, no, that's cool. And I want to ask you a little bit more about that later. I just couldn't pass up the opportunity to, as a foot and ankle subspecialist, to take the opportunity to call the hand the dumb foot, just because I got made so much fun of as an orthopedic surgeon specializing in the foot. So anyway, enough of that. So let's get into really the DEXA REMS conversation, because we get just so many questions about DEXA. We get questions about, what I hear that DEXA is potentially inaccurate. Tell me about REMS. Is REMS better? So I want to walk us through this conversation, but let's just start with DEXA. So everybody has access to DEXA. It's universally available for the most part. It is part of everybody's story with bone health, but there are weaknesses to DEXA. So can you walk us through, because you've done so much research on this, walk us through what you've learned about the weaknesses of DEXA and how big of a gap are we seeing from study to study? What is that margin of error that you've really come up with?
Right. So with DEXAs, like you mentioned, most of the time we're seeing people who are very concerned with their DEXA results. And I have to spend some time educating that 90% of DEXAs have errors, and those errors can range from anything as errors in input of demographic information to actual errors with regard to the positioning of the patient for the DEXA scan, and even errors in interpretation. So it is concerning that DEXA is considered our gold standard, yet 90% of DEXA reports have errors.
And have you come up with, because people ask me all the time, they say, oh, well, I got, my DEXA went up by 1%, and is that actually significant? Is that within the margin of error? And I know the companies that make DEXA, the different companies, they'll say that there is up to a 2% margin of error within the machine, but that doesn't include all the other potential errors that we could see clinically. So is there a range that we can hang our hat on, or is it just too hard to know?
That you're referring to the least significant change, which is when I see a change on DEXA, is this change real? And the number that we tend to use, comes from the ISCD, is 5 to 6%. So if you don't see a change of greater than 5 or 6%, that is not a real change. You can't hang your hat on that change.
Wow, that's a big number, 6%. Because most people are saying, oh my gosh, I improved 2%. I'm doing so well. Honestly, even when we look at data coming from the pharmacology side, if we're looking at big studies on pharma, they're not often, I guess after a while they are, but oftentimes they're touting 5 to 6% change, which would be within that margin of error.
Mm-hmm. It would be. You also have to consider that, LSC has to do with precision calibration of the machine. So if an institution is not performing those calibrations on a regular basis, they may not even have a reliable LSC listed on the DEXA report. So that's where the recommendation of 5 to 6% change comes in.
Yeah. Well, that's amazing. So one of the questions I get too often, I don't actually know how to answer it, which is when you're looking at a percentage change, a lot of times people are going to do the math off of the T-score, meaning like my T-score went from 2.7 to negative 2.5, right? Negative 2.7 and negative 2.5, it's getting better. And then of course you do the math on those two numbers and you come up with a percentage, that's a way to do the math, right? But generally we're talking about the actual bone density, right? So the actual, the much longer number. So when people are looking at how significant was my difference, can I look at the data and tell, how would you actually recommend that they make that calculation if we want to go down that pathway?
If we go down that pathway, they have to obtain the full report.
Right.
So I like to look at the DEXA very critically, and oftentimes people only have a report with numbers on them. They do not have the pictures. And so the pictures are the picture of the lumbar spine as well as the hip. So before I even start to recommend calculations to determine if there's a real change, I want to know if the DEXA is quality, because that can have make a huge difference on the percent change. If you go from a great quality DEXA to a not so great quality DEXA, then is this change real as well?
Yeah. And when people do the math, are they supposed to use, it's grams per centimeter squared, right? That's the actual density?
Correct.
Yeah. So should they be using the grams per centimeter squared number instead of the T-score to actually calculate an improvement?
Yes.
Yeah. It's frustrating when I look at literature, because I look at so much literature on bone health, usually those numbers aren't reported.
They're
right.
not.
So even if you're trying to read between the lines, you can't. You're like, well, all they reported was a T-score, and I can't get the data that I need. It's really frustrating.
Right. Yeah. The T-score is a way that people have been conditioned to monitor their bone health, and really they need to dive a little bit deeper. That being said, I always try to help people along, realizing that we're all aging, and there's an amount of bone loss that occurs with aging, 0.5 to 1%, just like we lose elastin in our skin and get some wrinkles. Our bones are aging as well. And so if they're looking at change, I try to really guide them to understand that you're still aging, and for you to think that you're going to increase your bone mineral density, I just don't think is a realistic approach. I think if you're within that normal loss of bone per as you age, then that's a win.
Yeah, I'd love to challenge you on that a little bit because
Okay.
if you pull all the levers, we do see it, right?
Okay.
But it takes a lot of stuff, right? And I'm not
Mhm.
talking pharmacology. I'm talking actually, doing it naturally. But we do see, for women that aren't on HRT, that go on HRT, if they're not doing resistance training and they start resistance training, getting adequate protein, we do see it, and we see it pretty consistently. So I would agree in the general population, I think that's the consensus, right? So like if you could stay on that average line, like this is good. But most people that are coming to us, they're already way below, and so they're desperate to catch up, and we can catch them up, but they have to have the capacity to do all the things.
I
So
agree wholeheartedly with that statement.
yeah, yeah. So that's where, and I think a lot of doctors will say like, oh, it's not reversible, and I could say like, well, like it is, but it's not easily reversible. You got to do a lot of stuff because it is hard to escape that, like, that inertia of aging. So you have to really
It
pull away
is.
from that. Let's move on from the potential errors of DEXA, and let's talk about the potential benefit of REMS. So can you give us, because I haven't done a video on REMS in a while. So can you give us kind of a rundown, like what is REMS? How is it different? And then I've got some very specific questions about fragility score, but give us the overview here.
Yeah, yeah. REMS is a ultrasound technology which is used to evaluate and diagnose bone health conditions, specifically osteoporosis, but it's also used to monitor over time. And it gives you a T score or a bone mineral density score, as well as a fragility score, which is a reflection of the microarchitecture. It takes about 15 minutes to do a REMS evaluation. The reports are generated at the time of the REMS evaluation. And if good quality data is not obtained from the REMS scan, a report will not get generated. Whereas with DEXA, reports are going to get generated regardless.
Yeah, unfortunately, right?
Yeah.
So then the biggest question I get about REMS versus DEXA, because I've seen some disparities between the two that are just gigantic. Is that a word?
Big.
That's humongous and gigantuan
Yeah.
altogether, gigantus.
Yeah.
So some really big changes. So for example, I think this was a couple weeks ago. I had a patient who had a T-score of -5.5 on DEXA and T-score of
Wow.
-1.5 on REMS. I mean,
Okay. That's
massive
huge.
swing. It's huge,
Yeah.
right? And so now I didn't have the images. I didn't have the full report for the DEXA. So I don't know, like, was it just obviously a terrible DEXA? But it was concerning because she had also already had a fragility fracture. So now she's asking me, well, which one do I believe? And I'm like, well, both. They're both
Yeah.
they're both valid to some extent. This is what I tell people. But how do you look at this when people say which one's quote unquote better? What do you tell people if DEXA is the gold standard? What can we say about REMS?
Right. When people ask me which one's better, I tell them they're two different technologies. And no matter the technology you're using, there's going to be wonderful things about it, and there's going to be some things that are not so wonderful about it. So pros and cons to every technology.
Mm-hmm.
I really encourage people to don't get so focused on the numbers, the DEXA numbers or the REMS numbers. You need to look at the overall person and put that together as a big picture. So you can have a great DEXA, like a normal bone density on DEXA, and you can still sustain a fracture, right? What the saying is approximately 50% of people who sustain fractures actually have osteopenia or low bone density. So
Mm-hmm.
regardless of the tool you use, you have to keep that in mind, that every tool has limitations, and it's part of the information you get from your tool is part of a bigger picture. I prefer to use REMS because I feel that it has less error it actually does have less error than DEXA. It's more sensitive with regard to picking up changes over time. The sensitivity is such, or the precision is such, that it can detect changes within a 6-month interval. I think that's a little overkill when it comes to monitoring bone health, unless there's a specific reason why, like, I don't know, an anabolic that's being used. I recommend just looking at using REMS once a year, whereas DEXA, it's, the changes you see in 2 years, and that's because of the least significant change. So that's it. That's what I tell people in a nutshell. Yeah.
Yeah. And I'm sort of falling into the same boat here, which is I think both tools provide data, and we have to look at as many data points as we can to come up with a plan. And that case example I talked about that's an extreme. Usually they are much closer, if not almost identical. But then what really separates the REMS data from the DEXA data is the fragility score. And this is I don't actually care really what the T-score difference is. I'm mostly interested in what the fragility score looks like. And let's go back to that case with that -5.5. If she hadn't had a fracture and her T-score looked good on REMS and her fragility score looked good, then I'm more likely to say, well, that DEXA T-score was really an outlier here. Let's consider you probably to have better bone quality than that. Her fragility fracture made it a little bit more confusing. But can you give us a sense of the fragility score? How does that actually happen on ultrasound? Like, how can we tell, you see somebody with the probe on the belly, they're looking at the spine. Like, how does that work? How do they know what they're looking at there?
Right. So that's kind of two different questions. We get B-mode ultrasound, so you can see the vertebral bodies on the computer screen. The fragility score is derived from the interaction of the sound waves with the bone. And so the way that technology works, or the AI works with that technology, is the sound wave goes down to the bone, interacts with the bone, bounces back, and then the artificial intelligence is able to separate skin, fatty tissue, soft tissue, and then bone. And then what it does is it compares the ultrasound signal for the bone of that particular patient with a database. And within that database, it compares that patient's signals with a 5-year age frame, and then says, is this patient's signal similar to people who have had fractures, or is it similar to people who have not had fractures? So if the patient's fragility score is, I'm going to use the term, in the green, that means the sound waves that come back, the raw data that comes back, is similar to people who have not had a fracture. Whereas if they fall within the red, their sound waves, the raw data that comes back and is analyzed, is more similar to people who have had fractures. And that's how the fragility score is derived.
Yeah. It's such interesting technology. I had a patient challenge me on this. He was an engineer. And so he was looking up data on it. And he said, how is it that you can look through the belly, which likely has gas in it, and see what's happening on the other side? And I tried to look up some information on that. But when you were trained, because I'm not trained to use REMS or ultrasound for that matter. So when you use an ultrasound, are you able to kind of get around gas bubbles? Is that a concern? Because I've heard that more than once.
Yes. So I instruct people not to eat or drink about 2 or 3 hours prior. Number one, when I'm trying to image L1, pushing on the abdomen can be a little uncomfortable if they have some food that has not moved on within their GI system, right? And sometimes there is a gas bubble in the intestines, and I can use the probe to push it in a different direction, or I can or I can manipulate the probe and get a different visual on that particular vertebrae. But occasionally I just can't see that particular vertebrae. It's not often that you see gas at more than one vertebra.
Right. Yeah, that makes sense. And then if you only get a good shot of 3 of the 4 that you're measuring, is that going to be an adequate scan?
It is. So similar to DEXA, the same rules apply in terms of you have to have 2 out of the 4 vertebral bodies in order to render a valid report.
Gotcha. Okay. So you got 3. Some other benefits of REMS, I've heard you talk about this, where there's it's not as sensitive to, say, arthritis or other things that might be back there. So is it where DEXA, you can run into issues, certainly with instrumentation, if somebody's had surgery, if they have arthritis, if they, like all those things. Is RIMS better under those circumstances?
Absolutely. REMS is not plagued by the shortcomings that DEXA has with when it comes to osteoarthritis, scoliosis, instrumentation, polymethyl methacrylate or cement. So as long as there is good bone tissue to analyze, the technology can analyze that tissue.
Yeah, that's cool. And I think also in younger individuals, avoiding radiation is another thing I say, even though DEXA is a tiny dose of radiation, but still. Mm-hmm. Less is better. All right. So then the follow-up to that is, okay, REMS has this fragility score, but I got a DEXA with TBS. Mm-hmm. So can you walk us through how TBS has been adapted to DEXA and how it compares to the fragility score from your perspective?
As far as I know, there's no data which compares the TBS to the fragility score. I know there are some people who are getting DEXA with TBS, and I think it would be really interesting to compare the two technologies or the information gained from the two technologies. TBS is a separate software package which is added to a DEXA machine, and it gives you information on the bone quality in the lumbar spine. It does not give information, or there's no TBS evaluation for the hips, whereas with REMS, there is evaluation of the spine and the hips.
That's an important point. Yeah. I've also been unimpressed too, because TBS will sort of give you these broad strokes of, your bone quality is great, or it's, mildly degenerative, or, poor. I'm like, well, I don't know what that means as far as what do I tell the patient? So clinically, it doesn't give me a lot of benefit. Whereas fragility score, because it's graded in such small gradation, it can really help me to understand, okay, this person's at higher risk of fracture, lower risk of fracture, et cetera. So I found that to be really helpful. So then now that so you're still practicing. So I jumped out of orthopedics altogether. I couldn't figure out how to do both. So kudos to you to some extent for being able to bridge this gap. So you're still practicing as a traditional orthopedic surgeon doing hand surgery. And then you also have your practice outside of this where you have a REMS, right? So you have this machine available to you. What would somebody expect if they were to come see you and tell us, kind of where you are and what you're doing in your practice?
Right. Thank you for asking me that. So for the large university network, I still do hand surgery, and it's exclusively hand surgery. The bone health part of my life is mine. So if anybody's interested in seeing what I'm up to with regard to bone health, it's www.qualisos.com, QUALISOS.com. I'm really dedicated to education and then just bringing REMS technology to various locations in the country, places that to people who may not have access to REMS technology. I'm currently not treating people for bone health, but certainly pointing them in the right direction with regard to people such as yourself who can help them with regard to treatment for their bone health. I really encourage people to work on lifestyle modifications because as you and I have talked about, there are things that we can control and there are things that are out of our control, such as genetics, the fact that we're female, our age, but we can certainly optimize all these other things to optimize our bone health. So that's where I am, Doug.
Yeah, well, that's awesome. And again, I think it's great. I actually miss quite a bit the work that I was able to do in the hospital and actually in the operating room. But I couldn't, as a hand surgeon, you have the potential to, not all hand surgeons can, but some hand surgeons can get out of general call and trauma call. And having to take care of the whole body. And I could not in our culture and environment here in Asheville, North Carolina. So I was sort of forced to either do all of it or none of it. So that's one of the reasons why I made that leap. But kudos for being able to stay in there. I do miss parts of that. Great. Well, any last minute or last things that you want to tell the audience about REMS, about bone health? What would you like to end off with?
Oh gosh, I think the most important message is to be kind to yourself. Don't get into the black hole of nitpicking every single number because you're going to drive yourself crazy, and just keep the perspective that you are an entire person and that you're more than your DEXA T-score or your REMS T-score and fragility score. The other point that I think we should make with regard to REMS is that the fragility score is more predictive of fracture risk than BMD is, whether it's acquired from DEXA or from REMS technology.
Yeah. No, that's such a great point. And BMD is bone mineral density for those that are new to this game. All right, Dr. Zambito, so great talking to you and getting caught up. And I look forward to sharing this with our audience. Of course, if they want to reach out to you, that website is the best way to get in touch. Is that right?
Yes, that's right. Thank you.
Okay, perfect. Yeah. And we'll link to that. I've got it right here on my browser. So we'll link to that so everybody can see what it is that you're up to. So thanks again. Appreciate your time.
Oh, thank you for your time, Doug. Thank you for having me as a guest.
Thanks so much for listening to this interview with Dr. Kimberly Zambito. If you are struggling to put all of your bone health components together for your own program and you haven't gone to our masterclass yet, consider going to our masterclass. There's a link on YouTube in the description, or you can go to our website, optimalhumanhealth.com, and you can find a link to sign up for the free masterclass there. That's where I show you how we put together programs, these customized, comprehensive programs for bone health through the lens of HealthSpan, and then we leave about 15 minutes for Q&A at the end. So if you haven't done that yet, please do it. I hope you enjoyed this interview. I'll see you on the next episode.